Hi, this is Philip Pador, founder of NCLEX RN 45-Day Challenge. In this video, I'm going to be talking about acute coronary syndrome. After viewing this video, you will be able to define the acute coronary syndromes, identify the clinical laboratory and electrocardiogram findings in acute coronary syndrome, manage acute coronary syndrome, and identify common complications of acute coronary syndrome. Acute coronary syndromes, or ACS, refers to a clinical condition causing myocardial ischemia. These conditions are characterized by an imbalance between myocardial and androgen supply and demand. The most common mechanisms involved in an imbalance that is caused primarily by reduction in oxygen supply to the myocardium. This most commonly results from coronary artery narrowing, caused by a thrombus that develops on a disrupted atherosclerotic plaque. This leads to a decrease in blood flow, and hence decreased oxygen supply to the myocardium. Other conditions that causes decreased oxygen supply include anemia, hypoxemia, hypotension. A less common cause of decreased oxygen supply is a dynamic obstruction, which may be triggered by intensive local spasms of a segment of coronary artery. This is called variant angina or Prince-Metal's angina. ACS may also be precipitated by conditions that increase myocardial oxygen demand, such as fever, tachycardia, or thyrotoxicosis. There are three types of ACS: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. We will talk about the key differences amongst these types in a few minutes. There are three cardinal signs and symptoms of ACS. The first is chest pain. Well, chest pain can be non-specific. Factors that make chest pains more suggestive of cardiac etiology include pain that is worsened by activity, radiates to the arms, neck, or jaw, or is associated with diaphoresis, dyspnea, nausea, vomiting, lightheadedness, or syncope. Keep in mind that chest pain may not be present in women, that elderly diabetics and post-heart transplant patients. These patients may have so-called silent myocardial infarctions. Another cardinal signs of ACS is abnormal cardiac biomarkers. These are substances that are released into the bloodstream when there is myocardial necrosis. The most commonly monitored cardiac biomarkers are myoglobin, troponin, and creatinine kinase MB, otherwise known as CK-MB. These markers vary in their time to peak levels and the amount of the time that they remain elevated before returning to normal. This graph illustrates that myoglobin is the first marker to peak within 2 hours, and also the first marker to return to normal with less than 24 hours. Troponin peaks next at 12 to 24 hours and remain positive on average up to 7 to 10 days. CK-MB peaks around the same time troponin at 12 to 24 hours but returns to normal more quickly in 3 to 5 days. Displayed here is a normal 12-lead ECG. It is beneficial to the developed standard system for evaluating ECG such as rate, rhythm, access, intervals, PR and SC segments, and PQRS and T-wave morphology. The colored box shows geographical groupings of ECG leads that corresponds to an anatomic locations on the heart supplied by a specific vascular territory. Leads 2, 3, and AVF corresponds to the inferior portion of the heart, which is supplied by the right coronary artery. Leads V1 through V4 corresponds to the septum and anterior portion of the heart, which is supplied by the left anterior descending artery. Leads 1, AVL, V5, and V6 corresponds to the lateral portion of the heart, which is supplied by the left circumflex artery. Here we can compare side by side a normal ECG with an ischemic ECG. The top left panel shows a normal ECG. Note that the ST segment is at a normal electrical baseline. This is defined by a segment between the T wave and the next P wave. The top right and bottom right panel shows findings seen with non-ST elevations myocardial infarction, either ST segment depression or T wave inversion. The bottom left panel shows findings typical of ST elevations myocardial infarction. Note that the markedly elevated ST segment with a convex or tombstone appearance. Here we will briefly compare and contrast the three types of ACS. In unstable angina, cardiac biomarkers are negative and there may or may not be a ST segment changes. This condition is due to myocardial ischemia without significant myocardial injury. In NSTEMI and STEMI, cardiac biomarkers are positive. The difference between these two entities relates to the degree of myocardial ischemia. In NSTEMI, there is a subendocardial ischemia which is reflected on ECG by a segment depression or a new T-wave inversion. In STEMI, there is a transmural or full wall thickness ischemia which is reflected on ECG by segment elevations. Over time, the ST segment normalizes and downward deflections at the beginning of the QRX complex forms. These are called the Q waves and represented dead myocardium. It is important to note that at the time of the presentation, patients with unstable angina and NSTEMI can be undistinguishable and therefore should be managed the same way. Appropriate management of ACS includes rapid identification of these life-threatening conditions. As we have already discussed, three cardinal signs and symptoms are chest pain, abdominal cardiac biomarkers, and ischemic ECG changes. Patients who present with chest pain suggestive of coronary ischemia should be further evaluated with 12-lead ECG and cardiac biomarkers. They should be given supplemental oxygen, full-dose aspirin chewed, sublingual nitroglycerin, and morphine. Anticoagulation is a key therapy for ACS. Patients should be treated with intravenous unfractionated heparin where the goal PTT of 50 to 70. They should also be given thienopyridine, such as clopidogrel or prasugrel. These are equivalent antiplatelet agents. Thus, it is important to monitor patients for signs and symptoms of bleeding while on these medications. For unstable angina and NSTEMI, patients will often require coronary angiography with potential placement of stents. This is called percutaneous coronary interventions or PCI. Patients with STEMI should be taken for PCI immediately. The goal is to have a guide wire across the culprit lesions in the coronary artery within the 90 minutes of the patients entering the hospital. This is called door-to-balloon time. If it is felt that a door-to-balloon time of 90 minutes can be obtained or a local hospital does not have the ability to do a PCI, then the patient should be given fibrinolytics within 30 minutes of the patient entering the hospital. This is called door-to-needle time. There are some situations where transfer to a center with the PCI capabilities is favorable over administering fibrinolytics. But this is outside the scope of this presentation. Lastly, patients should also be started on a statin beta blocker and an angiotensin converting enzyme inhibitor, as these medications improve outcome after myocardial infarction, even after a patient receives a life-saving reperfusion therapy. There are several complications that occur after a myocardial infarction. The most common cause of death in the first several hours following myocardial infarction is arrhythmia. For this reason, all patients with suspected myocardial infarctions should be on continuous cardiac monitoring or telemetry. Damage to the myocardium often results in left ventricular dysfunction, which can lead to congestive heart failure. Within the first 4 to 7 days, the risk from myocardial rupture is at the highest. This can lead to the death from compression of the heart by hemorrhage into the pericardial space. This is called cardiac tamponade. Ischemic damage to the papillary muscles may lead to rupture and results mitral regurgitation. More commonly, transmural infarcts. A large portion of the ventricular wall may become relatively immobile, which can lead to increased stasis in mural thrombus formation. In the first 2 to 3 days, there is the risk for development of pericarditis. Also, at about 3 weeks out, an autoimmune pericarditis can develop. This is called Dressler's syndrome. Lastly, ventricular aneurysms may also occur in areas of myocardial scarring at about 3 to 6 months out. In summary, ACS or acute coronary syndromes is a spectrum of clinical syndromes due to the myocardial ischemia caused by an imbalance in oxygen supply and demand. Rapid diagnosis requires the use of accurate history ECG and cardiac biomarkers. Treatment focuses on the reperfusion and decreasing myocardial oxygen demand, arrhythmia as most common complications and cause of death of post-MI.